talking about astigmatism control in very high myopes and with cylinders, and so it goes beyond the normal power that we would readily order. Okay, so this is a case of a very obsessive-compulsive urologist who grew up gaming, and so he would still like to continue gaming. It's a very high myope. Seen at another eye center, and he was told that he had a cataract a little more on the right than the left. Then he was also informed that his implant would have to be a monofocal due to his degree of myopia. Upon refraction, his right eye was 875 with a cylinder of 275, and the left was a minus 1250 with a cylinder of 200. His best corrected acuity was 2040 with difficulty, and the cataracts were assessed as such. He had no other comorbids that are important. Then upon doing his regular workup, we find that for a monofocal, he would need roughly a 1 to a minus 50 for a monofocal on the left eye and a 1 on the right. And this is non-toric. So I told him about the option of pre-ordering his implant. I told him it would take about 4 to 6 weeks before delivery to our country. And upon submitting all the requirements for the biometry, topography, and the potential power that he needed, I was told that this is what we would need. On the right eye, he would need a plus 1.20 with a cylinder of 4.28 diopter at 86 degrees. And then on the left eye, he would need a spherical power of 0.01 diopter and a cylinder of 4.44 at 87 degrees. So he had to prepay for this because it can only be used for himself. So he prepaid for the lens. We waited about 5 to 6 weeks. Then since he had a very busy schedule, he decided that he would have a immediate sequential bilateral cataract extraction. So we did FLACS on him and we put in the lenses. So post-op visual acuity on the right was 2016 with a near of Jaeger 3, and on the left it was 2016 with a near of Jaeger 1. On automated refraction, we would get about a minus 1.2 to minus 1.25, and this is expected. Needless to say, the patient was ecstatic, and he has mentioned that it's literally changed his outlook in life. He goes around telling people in the elevators of the hospital that I did his eyes, it's never seen better. So it's like a walking advertisement now, and everybody used to see him with very thick glasses. Just a note, the validity of AR for a segmented refractive multifocal intraocular lens has been shown to really have a reading which is an average between your distance and your reading segment. So if your reading segment is roughly 250 or 300, you expect to get an AR reading of a 150 or a 125, depending on what you put in. So don't get misled by your AR. If your patient's seeing 20/20 or 20/15, then they're fine. Okay? And so the aviation cocktail, we fill a cocktail shaker with ice. Well, that's when you let the patient understand his cataract and refractive problem. You add the gin, the liquor, creme de violette, and the proper screening tests or the topography, biometry, OCT. You shake vigorously. Explain this only possible option is a customized IOL. So you wait until it's well chilled, and then you double strain into a chilled martini glass. You pre-order the IOLs and wait for delivery. You garnish it with a maraschino cherry or a lemon twist, and you perform the surgery and let the patient enjoy perfect, refreshing cocktail of vision. Thank you. For ametropic patients with very high grades, have not much of a choice. They will often end up with physicians who will tell them that, well, there's no choice, so let's just correct what we can. Let's leave the astigmatism behind. Let's make you monofocal. You will need spectacles after this. Whenever the powers that are needed for my patients go below 5 or 6 diopters and require astigmatic or toric correction, I would then have to pre-order these lenses. I do this customization with the help of Teleon LENTIS IOLs because they're the only ones that go all the way down to 0 and all the way to about 30 plus diopters for spherical correction. Their cylindrical correction reaches about 10 diopters, and the increments of these customized implants are actually at 0.01 diopter. Hardly anyone else can manufacture something to that level of accuracy. I've actually done quite a series of these patients through the years. Every time I get someone with myopias over 10 to 15 diopters and hyperopias of about 10 diopters, I generally will tell them I will be needing an M+ LENTIS IOL because nothing else can give them this range of powers, especially since I want to also correct toricity. We have to understand that global studies that have shown that from about 23% to about 47% of most of the population will have at least some mild form of astigmatism of 1.5 diopters or less. And this needs to be corrected. Anything that will not correct that fully will not result in very good results.